The next lecture will be, the topic will be taking a load of to Dr. Lalantha Senaratne to further to explain of him that Dr. Lalantha Senaratne is a specialist in family medicine, functioning as a clinical head in the primary care settings at Base Hospital, Maharagama. Oh, sorry, Homagama. I'm sorry. She is a trainer, a mentor, and a chief examiner of both undergraduate and postgraduate trainees in family medicine, and serves as a council member in the College of Palliative Medicine in Sri Lanka. Dr. Senaratne contributed as a chairperson in Wonkasa conference in 2016, and she has numerous publications in both national and international journals. She is a functioning president of our college, Sri Lanka College of Specialist Family Physicians. Now, Dr. Lalantha Senaratne gives to you over your presentation.
Taking off load means the patient comes with lower limb swelling. It's not a disease it's not a disease to manage. It's a symptom. So we have to understand how you assess the patient comes with lower limb swelling. I think it's a very common encounter in primary care setup. So this is the reason I have chosen this topic, as well as a request came from our organizing committee as well. Right. So I would like to introduce as like this. It's lower limb swelling is a common and challenging diagnostic problem, because it's sort of not a disease, it's a symptom. So it could be the reason, maybe a lot of reasons behind this. And second thing is, it may present to the clinician in several ways. And the etiology is often multifactorial. So we don't say this is because of this reason the lower limb swelling came, because there is multifactorial. And the symptoms can be debilitating, and this impact the quality of life of patients. So we have to consider everything when we assess the patients with coming with lower limb swelling. The presentation is different. It could be the patient comes with unilateral or bilateral. They comes with the swelling in one leg or both lower limbs. Or else it comes as acute or chronic. Maybe it's very short duration or very long duration. Or else it can come as painful or not painful. Because I've told, the etiology is multifactorial. There are several etiologies. The well-known ones, it could be infection can cause lower limb swellings, and inflammation, it could be vascular, it could be due to trauma, or immunological, or malignancy, or it could be metabolic. So our aim is to identify which is the cause for the lower limb swelling without just give any medicine for patients. Right. So objectives of the assessment. We must have some objectives when we assess patients. The objectives should be understand the etiology. What causes, why the patient present. And then this is where we must have the accurate diagnosis. Otherwise, we treat patients haphazardly without knowing the reason. And then degree of disability and cost-effective diagnostic testing. We don't have to do all the investigations for patients. If you do not know the etiology, only we do all the investigations. So our one objective is to understand what is the etiology, and we have to choose which is the best diagnostic tools or what are the investigations available. And then comprehensive management plan. So the people are debilitating, as well as there are a lot of they have disability with the swelling, and we know what's the family matters and everything, and we need to have a very comprehensive management plan for these patients. Right. So I just want to give the definition of the lower limb swelling. Mainly, it's sort of what we say as lower limb swelling here is a edema. It's, of course, why we say it's defined as a swelling caused by an increase in interstitial fluid that exceeds the capacity of physiologic lymphatic drainage. And I would like to come to that slide again. It occurs due to accumulation of fluid in the subcutaneous tissues leading to volume expansion. Expansion of the interstitial fluid volume could be generalized or localized. That is why the patient comes with either as a localized swelling or the generalized swelling. If you do not know that, if you don't understand the physiology, it's very difficult to find the pathological reason for the swelling. Yes. So physiology of the microcirculation, I would like to talk about the microcirculation. Yes. The expansion of the interstitial fluid volume is prevented, or usually is prevented by few mechanisms. It's because there's a tight balance of hemodynamic forces, what are you call as Stalin forces, along with the capillary walls. As well as this depends on three factors. First is vascular hydrostatic pressure, plasma colloid osmotic pressure, as well as adequate function of the lymphatic vessels. All three things are important to have the interstitial fluid is in a normal without having any expansion. Yes, normally we'll talk about the physiology. Normally the outflow of the fluid from the arteriolar end of the microcirculation into the interstitium is nearly balanced inflow at the venular end. A small residual amount of fluid may be left in the interstitium and is drained by the lymphatic vessels. Finally, the fluid in the lymphatic vessels, that means it comes as lymph, returning to the blood stream via the thoracic duct. Yeah, this is the way. This is the arterial end at the venular end. The hydrostatic pressure in the arterial end is very high. But anyway, so this is how the balance, you can have a minor mathematics there. The arterial end, the pressure, hydrostatic pressure is 37, as well as the oncotic pressure and the interstitial pressure is 25 and 1, altogether 26. You can deduct what is the difference, as well as the venular end. The hydrostatic pressure is 17, and the difference is, the minus, and there's only 2 gap. So that it's only minute difference, very small difference there. Because of that, there is not much of fluid in the interstitial fluid. But if there's any changes in the arterial end or the venular end, that means that if the hydrostatic pressure is going up wherever the way, definitely the interstitial fluid is going up. Or else, if the oncotic pressure is going down, yes, the interstitial fluid is going up. So we have to find out, as a cause, what actually happens to the patient, whether the hydrostatic pressure goes up, or any sort of oncotic pressure is going down, or any sort of the lymph. This is the diagrammatical way I have got from internet. And the arterial end and the venular end, the fluid in the interstitium, that is the thoracic duct. And if there's any problem in wherever the place, the interstitial fluid goes up. And even the thoracic duct, is there any sort of blocks, it can cause the accumulation of fluid in the interstitium, what we call as edema. Yeah, so we have to understand what are the causes of increased hydrostatic pressure. It's very crowded, I saw. So there are several causes. I put some examples as well. First thing is, we say the increased plasma volume due to renal sodium. So that means, sodium retention. It's mainly, we can guess, like the heart failure. What happens is this. There are a lot of examples. I put heart failure just to explain to you all. And then any sort of venous obstruction, with that the hydrostatic pressure goes up at venular end. And the things what we can get examples, cirrhosis or hepatic venous obstruction, acute pulmonary edema, local venous obstruction, that means DVT, and external compressions, like even a mass or plaster, yes, it can cause. And failure of venous pumps, failure of venous pumps, paralysis of muscles. That means after CVA, there's paralysis of venous paralysis of muscles. It can cause failure of venous pumps. So we have to consider everything when you assess patients. And immobilization of parts of the body, even after post-op, after fractures, you have to consider those things. And failure of venous valves, as you say, the varicose veins. And the other one is causing the increased hydrostatic pressure is decreased arterial resistance. I gave some drugs, you know, the medication, what we use, as well as idiopathic edema. I'll come to that later. What is idiopathic edema? Yes, these are the causes of decreased capillary oncotic pressure. Is very, very well known. You know, everybody, you know that. And hypoalbuminemia is the main cause. And we can choose either protein loss or failure to produce proteins. As protein loss, you know, loss of proteins in urine, nephrotic syndrome, and GIT, that means protein loss in gastroenteropathy, or loss of protein from denuded skin areas in after burns or severe wounds. As well as the failure to produce proteins in case of liver diseases like cirrhosis or serious protein or calorie malnutrition. Yes, this is increased capillary permeability. Other than that, if the capillary permeability is high, again, you know, there's increased fluid in the interstitium. So the immune reactions that cause release of histamine and other immune products, that means after an allergy. So that's either mast cell derived or bradykinin mediated angioedema. So in these instances, there is increased permeability of vessels. And the same thing will happen after the exposure of toxins, like toxins as well as adult respiratory distress syndrome, inflammation after sepsis, vitamin deficiencies, especially vitamin C, and prolonged ischemia, burns again, and diabetes mellitus, remember, as well as trauma. And causes of lymphatic obstruction. I told you the different levels, how it happens. This is the obstruction. What happens is, and cancers due to nodal enlargement, infections after filarial or nematodes, surgery, lymph node dissections, congenital absence of abnormality of lymphatic vessels, or post-irradiation. In those instances, there's some sort of lymphatic obstructions. Yes. So the clinical manifestations, those comes as, you know, as I mentioned at the beginning, it comes as unilateral or bilateral. So unilateral could be either primary or secondary causes are there. It could be, you know that it's unilateral DVT, primary venous diseases, post-thrombotic syndrome, lymphedema, reflux sympathetic dystrophy, infection, masses, tumors, or radiation. There are some primary as well as secondary causes. As well as, you know, the bilateral generalized swelling, it suggests systemic etiology. Think if it is bilateral, think of some systemic etiology. So, for instance, I can give some examples, either acute heart failure, chronic, the unilateral DVT, as well as chronic venous disease there, as post-thrombotic syndrome, pulmonary hypertension, lymphedema, lipedema, idiopathic edema, even obesity can cause endocrine diseases like thyroid diseases, spinal cord injury can cause bilateral edema, immobility, and obstructive sleep apnea, as well as the medications we use day to day. So I would like to give you attention to the medications every day we use which can cause edema or swellings. Especially the antihypertensives, the calcium channel blockers, as you all know, and beta blockers, clonidine, hydrazine, minoxidil, methyl-dopa. If you use, then, you know, we have to go for the drug history. What are the medications they take for their, the managing hypertensions, whether it can cause the swelling. Or else hormones like corticosteroids, estrogens, progesterone, testosterone, pregabalin, and gabapentin. or the chemotherapy. So those are the things, the medication we have to think of if there's a patient who comes with lower limb swelling. Yes, the clinical assessment. This is very important, the onset. So if it is acute or chronic, so acute means less than 72 hours. If the swelling is less than 72 hours, we consider it as acute. And it's more characteristic of etiologies such as, I give some sort of examples, DVT, infections, trauma, exacerbations of medical conditions such as even congestive cardiac failure or recent medication. If you change some medication, it also we have to consider that. So when you get the history, give some sort of think about all these things just without giving any medication to people. And chronic causes, chronic swelling may be due to venous insufficiency, lymphatic dysfunction, as well as the other examples I've given. So the other clinical assessment we have to think about whether what is the distribution, whether it's unilateral, it's bilateral, or generalized. So we have to consider those things before you give some medicine for patients. And the severity with position and the time of the day, either prolonged standing or more swelling at the end of the day, or especially for the associated symptoms. If it is bilateral or generalized, please go through all these associated symptoms such as palpitation, presence of angina, change in bowel habits, appetite, urinary symptoms, pain on walking and resting pain, presence of fever, itching, etc. Yes, examination, when it comes to examination, the general examination, you have to consider this, the pattern of distribution of edema. As I mentioned, the presence of dyspnea, pallor, clubbing, cyanosis, icterus, as well as presence of skin pigmentation, hemosiderin deposition in chronic insufficiency, skin temperature within acute DVT and cellulitis, and presence of ulcers. Venous insufficiency is indicative of, if there's an ulcers, is indicative of venous insufficiency. And evidence for endocrine disease like diabetes and thyroid. Yes, physical examination for the systemic diseases, the causes. Yes, if you think of, as you all know, the pulmonary edema, you have to look for those things in quickly. So the tachypneic, where the wet rails on auscultation, gallop rhythm is indicative of those things, and heart failure, tachycardia, raised jugular venous pressure, lung crackles, pleural effusion, ascites, hepatomegaly. So before you do anything, you have to examine the patient carefully. And renal failure or cirrhosis, jaundice, palmar erythema, spiny nervi and tremors, angiomata, and gynecomastia, ascites, all the things there. And the renal failure, again the tachypnea, tachycardia, reduced pulse pressure, anemia, hypothermia and tremors. As well as for thyroid disease, the signs of hypo or hyperthyroidism. Right. The investigations, when it comes to investigations, if a systemic issue is suspected, you have to do these things. It's the basic ones first. The complete blood count, creatinine, urine analysis, thyroid panel, atrial nitric peptide, hepatic enzymes, and albumin level. Or these things, it's according to the presentation, not for each and every patient. And we can consider the duplex studies, imaging, ultrasound, CT, MRI, venography. It depends on the patient's assessment. After the assessment, you have to decide what are the investigations you should perform. But remember, I have put, if a systemic issue is suspected, please consider the investigations. Yes. Clinical presentations. I would like to, do some sort of in a very interactive way, because I give some case scenarios of the clinical presentation. You all can contribute. The things I have given you the information already, so you better go through those things and give your opinion about the management, right? Mrs. DS, 72 years, brought to you to the clinic with a complain of bilateral lower limb swelling, which is more at the end of the day and prolonged standing and walking. This is what the person, how the person present to you. And you go through again the history, there's uneventful past medical history, not on any long-term medication. The examination, there's localized dependent edema, normal peripheral pulses, jugular venous pressure is normal, lungs, abdomen, and all clinically normal. So anyway, there's no need of go for any investigations, but the basic investigations are normal. So what do you think about the possible diagnosis here? According to the sort of the priority, if you had to, there are a lot of causes, I mean, it could be whatever the risk things as well, but it's the most probable diagnosis here. What are the things we have to consider here? Anybody who wants to answer? This, of course, we have to understand dependent edema caused by venous if insufficiency is more likely to improve with elevation and worsen with dependency, right? So this the person, you know, it's 72-year-old patient without any complications. And dependent edema is an otherwise well patient suggests a benign cause such as immobility. Mechanical therapies are indicated like leg elevation, compression stockings, so graduated compression therapy helped by calf muscles pump help to reverse the process. Compression therapy is contraindicated in patients with peripheral arterial diseases. Measurement of ankle brachial index should be considered in patients with the risk factors for peripheral arterial disease before prescribing compression therapy. And this is what I want to highlight here. Diuretic therapy should be avoided without presence of a comorbid condition. So it's a very plain and simple just edema because of immobility. So don't give unnecessary diuretics for patients. Yes, this is the second clinical presentation. A 58-year-old, only 3 minutes more. A 58-year-old male presented with bilateral lower extremity swelling and shortness of breath on exertion of 3 months duration. His symptoms have progressed to include fatigue, orthopnea, and cough productive of clear sputum. His leg swelling is exacerbated by long periods of sitting. He did not have fever, chest pain, palpitation, hemoptysis, rash, or urinary symptoms. The patient denies use of alcohol, drugs, or medications, and he eats non-vegetarian diet. Past medical history, hypertension for since last 10 years and taking treatments. So examination, pulse is 82, jugular venous pressure is elevated, lungs, yes, there are crepitations in lung bases, abdomen, there are ascites. So investigations, we have ordered all these things. Now it's very clear in this patient why we want to treat. Yeah, so we have to understand the edema in heart failure. What happens in edema in heart failure? You know, it begins with increased venous pressure. As I mentioned in causes, its physiology I explained. And early in the heart failure, what happens? Renin-angiotensin-aldosterone system, RAS, is activated as a compensatory mechanism because of the impairment of the renal blood flow. First of all, there's venous pressure, and then as a result of that, RAS is activated. And then with the progression of the disease, it assumes a detrimental role responsible for increased preload and afterload, which are the hallmarks of clinical heart failure syndrome. Finally, what happened? Hypoalbuminia secondary to liver stasis. This is not one reason. There are several reasons for patients with heart failure. The edema causes due to cause several reasons. So you know you have to treat each and every stages, and you know that's why we give furosemide as well as spironolactones to stop each and every level. And edema in liver failure is the same as that. It's a little bit dark. It develops ascites and then edema in the lower extremities because of an increase in venous pressure below the diseased liver. The venous pressure above the hepatic vein, including the jugular veins and right atrium, is usually reduced or normal. So this is a good thing for you all to understand. In the earlier one, the jugular venous pressure is high because the pressure in the right atrium is high. Here, the right atrial pressure is low or normal. And because of that, the jugular venous pressure is not elevated. Liver pathogenesis leads to decreased synthesis of proteins, and the hypoalbuminemia leads to decreased oncotic pressure. Now you know how it happens, the edema. The scarred liver also causes a back pressure in the portal vein territory, that means portal vein hypertension, and increases the hydrostatic pressure. So hydrostatic pressure is also going up. And these two factors combined lead to edema in the peritoneal cavity, that means ascites, and this in turn compresses the inferior vena cava and leads to edema in the lower limbs. The presence of other signs of portal hypertension such as distended abdominal wall veins and splenomegaly. So there are only two things, so that is how the comparison. So for the since we don't have much time, I just rushed. So this is the comparison about the central venous pressure and all these things in cirrhosis and all the other conditions. And I have two more clinical things I have given to this. So clinical presentation number 3, Mrs. NKP, 35-year-old mother of 2 children, presented with myalgia, swelling of the face and legs and bloated abdomen of 2 weeks. She also complains of on and off headache of same duration. Headache was intermittent and mostly over frontal area, but her main worry was swelling of the body. She was previously a healthy woman who is a seamstress and managed to work at home without a helper. Her husband is a businessman and busy with his work. You know, past medical history and others are uneventful. The examination says swelling in face, hands and legs is normal, peripheral pulses, GAVP is normal, and the other rest of the things are normal. So because of the time constraints, I would go for the diagnosis, what you call as idiopathic edema. Here, a syndrome is a syndrome of real low perceived fluid retention with swelling of the face, hands, trunk and limbs, the absence of cardiac, hepatic or renal diseases. It commonly occurs in premenopausal women. Diabetes, obesity and emotional problems including depression and neurotic symptoms are commonly part of this syndrome. It may develop periodically or it may persist over time. Swelling of the face, hands and legs can develop rapidly, and affected individuals typically experience significant changes in their weight over the course of the day. I rush all these things, how to manage the idiopathic edema. Most individuals with idiopathic edema experience a decrease in swelling and fluid retention with the introduction of low sodium, low carbohydrate diet. For individuals already taking diuretics, a brief discontinuation may result in symptoms improvement as well. Individuals who do not respond to initial treatment may be difficult to treat. However, there are some studies show the other therapies such as ACE inhibitors have shown success in some cases. The last one, give me a few seconds. A 52-year-old woman presented with painful swelling in both legs without much involvement of feet. It was a persistent swelling which does not change with posture or gravity. She also experienced easy bruising and tendon touching. Uneventful past medical history, not on any long-term medication. Examination, bilateral symmetrical swelling in leg, no swelling in feet. No swelling in feet, right? Normal peripheral pulses, jugular venous pressure is normal, legs, abdomen, all clinically normal. So, how do you proceed? Yes, what you call as lipedema. Lipedema is a loose connective tissue disease characterized by a disproportionate accumulation of adipose tissue in the limbs of women. Despite its incidence of 10 to 20%, lipedema is often undiagnosed and misdiagnosed. There is impairment of fatty tissue distribution and storage combined with hyperplasia of individual fat cells. Swelling, which is tender on palpation, is seen in both lower limbs except for feet. Conversely, lymphedema generally does not elicit pain on with palpitation. This, here is very painful on palpation. Treatment protocols comprise conservative. So maybe this there's no much sort of a treatment, but decongestive lymphatic therapy and surgical liposuction is the other approaches. Early diagnosis and treatment are mandatory for this disorder, otherwise gradual enlargement of fatty deposition causes impaired mobility and further comorbidities like arthrosis and lymphatic insufficiency. So these are the differences. You can see the top one and the bottom one. The top one is lymphedema. This is lipedema. The feet is intact. There's a feet is also involved. So this is, you can see the differences between the lipedema and lymphedema. The other one is Kaposi's stemmer signs in negative. So I don't have time to do it because lymphedema is, I think, so very common. So these are my references. Only one thing is left, but it's just, lymphedema, we know. Okay, fine. Thank you very much. All the questions we'll take after the session. Okay, thank you.
Thank you very much, Dr. Lalantha, for your excellent and very informative lecture on a subject which is quite common in primary care.